hypertension. We talked about how there's all these different standards, but I want you to know the ACC/AHA guidelines, okay? You don't need to sit there and spend time memorizing the JNC or the ISH guidelines. Just focus on the ACC/AHA. That's what you're going to be tested on. Just realize when you get out of here, there are other guidelines that folks may be following that you just need to be familiar with. The other thing on this slide to kind of highlight is you can't go off of one abnormal blood pressure level to say this person has hypertension. You need at least 2 or 3 abnormals to be able to diagnose somebody with hypertension. Then we talk about how there's different definitions. There's primary hypertension, which is we don't know of any other etiology that's causing it. And then there's the secondary, where there is another medical condition that's going on that is causing elevated blood pressure as a symptom of that condition, okay? So just knowing that there's additional causes, because secondary hypertensions may be very difficult to manage and get to goal if you're not actually treating the problem that's causing it. Other definitions, so white coat hypertension, that's repeated in-office readings are elevated, but they're normal at home, which a lot of our patients are going to complain that that's what's going on when it's not, but that's what the definition of white coat hypertension is. Masked hypertension is going to be almost impossible to diagnose and treat, because when they come to see you in the office, they have normal blood pressures, but when they go home, they have abnormal blood pressures. And then another term to just be familiar with is resistant hypertension, which is even though these folks are on multiple agents, like 3 separate agents optimally dosed, you still cannot get them down to goal blood pressures. And then just be familiar with some of the things that could cause a false elevation in your patient's blood pressure, so that when they come back for their repeat, you can counsel them about these things to try to avoid, so that we can get an accurate blood pressure check read, so we're not treating a full bladder that's causing the blood pressure to be elevated. And then we talked about ambulatory blood pressure monitoring, and how this is a great and probably the most accurate way to assess somebody's blood pressure. There are some challenges to why we don't do this more regularly, but it is the most accurate way to check somebody's blood pressure. And then we talked about the USPSTF actually has recommendations for screening, and it says to screen all 18-year-olds and older, at least on the initial check every 3 to 5 years, and then do annual screening once they get to 40, or if you have a patient who's at an increased risk of hypertension. So annual after the age of 40, or if they're at risk, but USPSTF recommendations say start screening for blood pressure at 18. And then when you go to make that diagnosis of hypertension in your patient, just be familiar with the baseline labs that you need to do for these patients, okay? And the reason we do this is, one, looking for secondary causes of the hypertension, but also we need to determine what our goal should be, and the way we determine our goal is calculating that ASCVD, right? So there's going to be some labs that we're going to need to do in order to assess what their risk is, so we can determine what our treatment goals should be. And then we talked about primary hypertension. We talked about the risk factors could be just getting older, inactivity, obesity, other things like diabetes, smoking, all can put somebody at high risk of developing primary hypertension. And we talked about how there's the formula that goes into calculating blood pressure is cardiac output times the total peripheral resistance. And then we talked about how when you look at each of these factors, you can see there's so many more systems in place to elevate the blood pressure. There's really not many mechanisms in place to lower blood pressure unless you're looking at like the local regulators, okay? So your body is designed to maintain a higher pressure because it realizes that low pressure is worse than having elevated pressures, okay? And then this is our treatment goal according to the ACC/AHA guidelines. Our treatment goals if you have a patient who has a 10-year ASCVD risk of 10% or higher, is getting them down below 130/80. So getting them out of that stage 1 hypertension range. If they have an ASCVD risk that is less than 10, then it's reasonable to shoot for a goal of getting them out of that stage 1, but it's not like a highly recommended thing. It's reasonable to do it. And then we talked about the different ways that we can treat it, and we talked about the non-pharmacologic things that we can do. We said that the DASH diet is the most important, or the one that is the most effective at doing it, but there's so many other things like physical activity and losing weight that can have a profound impact on lowering blood pressure even without giving them medications. And we talked about smoking cessation, how that's key. We talked about stress management techniques because we're trying to get rid of that overstimulation from the sympathetic nervous system that's causing that vasoconstriction and everything like that. Caffeine reduction can help as well, although we don't typically see chronic elevations of blood pressure with caffeine use like we do with nicotine. And then we talked about the DASH diet. Please don't memorize all these different servings, but just know what this is, but just knowing that this is just a healthy diet, fruits and vegetables, those types of things, has the most impactful results with lowering blood pressure. And then we got into the medications. We talked about, we really have 4 main groups of first-line medications to treat high blood pressure. We talked about our thiazides, our ACE inhibitors, our ARBs, and then our dihydropyridine calcium channel blockers. Those are our first-line agents. And we talked briefly about how each one of these agents work. We talked about how ACE inhibitors work on preventing that conversion of angiotensin 1 to angiotensin 2, so you don't get the direct effects of angiotensin 2 causing that vasoconstriction, but you also then block that stimulation of angiotensin 2 on the adrenal gland to cause the aldosterone secretion, which then leads to sodium and water absorption. So ACE inhibitors work there, but they also work at preventing the breakdown of bradykinin into the inactive peptides, which then means we have higher concentrations of nitric oxide circulating, which, remember, this has a local benefit of a vasodilatory effect on blood vessels. So ACE inhibitors work in really 3 different ways in order to lower blood pressure. But because of that bradykinin, higher bradykinin levels can cause the side effect of cough. We have the angiotensin receptor blockers, the ARBs, that we can use for those patients who don't tolerate ACEs because of cough. Okay, and this just works at one step down, where it blocks angiotensin 2 from binding to the blood vessels to cause that vasoconstriction, and then also blocking the stimulation of the adrenal gland to release aldosterone. So, and it doesn't have any impact on bradykinin, so these don't typically carry cough as a side effect. But then we also talked about how ACEs and ARBs are absolutely contraindicated in pregnancy because of serious harm to the baby. So if a patient becomes pregnant while they already are on medications for blood pressure, or they have a new diagnosis of hypertension during their pregnancy, you're limited on what you can give to them. And really you come down to just methyldopa, labetalol, or nifedipine as kind of the main ones that you can give to these patients. And then the side effects for ACEs and ARBs are similar. The only one that makes it unique is this cough. And again, it's because of the increased bradykinin levels. Then we went in and we talked about thiazide diuretics, and we talked about how these are great. There is morbidity and mortality benefit from thiazides. They are effective, and they typically do well, even tolerated by most patients, except for ones who have pretty severe kidney function decline. So if their creatinine clearance is less than 30, then they should not be on a thiazide diuretic. But then we also talked about how patients who suffer from gout probably should not have thiazides because it can increase the risk of gout flares by decreasing the clearance of uric acid. So it just maintains a much higher level of uric acid in the blood, precipitating those gout flares. Then we talked about potassium-sparing diuretics because we're focusing on the diuretics. And we talked about how these really aren't great for monotherapy for blood pressure because they don't really have the same effect like the thiazides do as far as lowering blood pressure. And they do carry some additional side effects like the hyperkalemia. So basically, unless we have certain specific conditions where these potassium-sparing diuretics would treat those things, usually we're using it more of like an anti-adrenergic kind of thing in women with PCOS to kind of block that hirsutism and resistant acne. That's usually what we really limit this to, unless there's two conditions that you can use these for, but we'll talk about those later. Then we talked about the calcium channel blockers. And remember, there's two flavors of calcium channel blockers. The dihydropyridine are the ones that you want to think of when you're talking about blood pressure in isolation, okay? Because they have much less impact on cardiac function, like the contractility and the inotropy, but they have more of that vasodilatory effect. If you did need a calcium channel blocker to affect the heart rate, then you're going to be looking at your non-dihydropyridines, which is your DILT and your verapamils. But for blood pressure, be thinking of the medications that end in -pine to have more of a profound effect on blood pressure. And the biggest thing, they work great, but the biggest side effect that usually will limit people from being able to tolerate this is ankle edema. Just causes some swelling in the lower extremities at the end of a long day. So those were our primary agents, but then we talked about some other agents that could be used in conjunction, or we need to be careful if we were to prescribe these to treat a different medical condition. We need to be careful about their effects on blood pressure. And the first one was alpha-1 adrenergic blocking agents. And typically we're using these now because to treat elderly male patients who have BPH to help them be able to urinate better. But this can have blood pressure lowering effects, so you got to be careful because you don't want to lower the blood pressure of an elderly patient too far to the point where they're passing out, falling, and hitting their heads. So be careful about using these agents in patients with low blood pressure, or if they're on multiple agents already for blood pressure, just know that it's going to lower blood pressure as well. And then we talked about alpha-2 agonists like methyldopa and clonidine, and we talked about using these in pregnant patients with methyldopa, but because of the poorly tolerated side effects from these medications, that's why these are not first-line agents. And so we typically only use these in situations of like hypertensive urgency and hypertension during pregnancy. So those really are the only two times we're using these agents. Then we talked about beta blockers, and you have labetalol, which has a lot more of an antihypertensive effect when compared to like metoprolol. But we usually don't use these as first-line agents because of it's not as good as some of the other agents in lowering blood pressure. But the one kind of caveat is we do use labetalol in hypertensive emergency as well as hypertension in pregnancy. And we just got to be careful of the side effects that come along with beta blockers. So we can slow the heart rate down too low. It can cause some sleeping problems. It can even cause depression and sexual dysfunction as well. Then we talked about the direct-acting vasodilator like hydralazine, and this is not a first-line agent, but we use this in pregnancy, like hypertension in pregnancy, like preeclampsia, eclampsia kind of conditions. We also use it in hypertensive emergency, because we can give it in IV form. But one of the common ways that we will give hydralazine is in our African American patients with heart failure who would benefit by being on a dinitrate hydralazine combo. And then we talked about, according to the ACC-AHA guidelines, there is a treatment algorithm on how to manage your hypertensive patients. And usually stage 2 hypertension, we're thinking both non-pharmacologic and medications. If there's stage 1 hypertension, meaning that their systolics are in the 130s and their diastolics are in the 80s, we need to calculate that ASCVD risk to determine if we should do just non-pharmacologic therapy by itself, or if we should add blood pressure medications to their treatment. So, so stage 1 hypertension, looking at their 10-year ASCVD risk. And then some other additional patients that maybe you want to modify how you treat them. For African Americans, first-line agents should be thiazides or calcium channel blockers. They tend to not respond as well as other populations to ACEs and ARBs. And then for diabetics, consider having them on ACEs and ARBs just for that renal protection. And it is recommended if you have a patient with chronic kidney disease and having blood pressure problems, then they should be on an ACE inhibitor as their primary agent. If they can't tolerate ACEs, then they should be on ARB instead. And then when you start somebody on antihypertensives, you got to be careful of the secondary side effects associated with it. And usually we're thinking of electrolyte abnormalities that could develop. So just being familiar with the types of electrolyte derangements that can happen simply by being on this medication. So for instance, thiazides lower potassium and lower sodium. ACE inhibitors and ARBs both raise your potassium levels. So if we were to put them, these patients on ACEs and say an mineralocorticoid receptor antagonist like an aldosterone antagonist, you can see we're going to be raising their raising their potassium levels with both of those medications. So we have to watch them very carefully that we don't throw them over into like a hyperkalemic state. Okay. So now we went on to talk about secondary hypertension. We talked about how in secondary hypertension there is a specifically identifiable condition where hypertension is now a symptom of the condition and not a pathology itself. Okay, and there's some warning signs that maybe we could be on the lookout for that might make us suspicious for a secondary hypertension case. And we talked about there's several different forms of this, and we talked about renal causes of secondary hypertension, and the most common one was renovascular disorders. So the blood vessels going to the kidney or within the kidney are the problem. And we talked about how renal artery stenosis, typically in elderly male or those patients who are high risk for atherosclerotic disease in the first place, they are at risk of having this form of secondary hypertension where the blood flow to the kidney is impacted, so the kidney perceives it's not getting the flow it needs, and it activates the RAS to try to improve that blood pressure. But as we all know, this is actually not what's going on, and it ends up having the negative effect of raising the blood pressure too much at the expense of trying to get more blood flow to the kidney. Then we talked about the other kidney problems where it's actually the nephron, the filter system of the kidney is the problem. In conditions such as like diabetic nephropathy, where the damage to the filter is done, so you're not filtering things properly. And what ends up happening is your kidney function starts to decline. That reduced GFR is perceived by the kidney, and it thinks the way to fix it is activate the RAS so that it can improve perfusion and flow and filtration in the kidney. What kind of helps differentiate these patients from the other form of kidney causes is these folks are going to have abnormal labs associated with them, abnormal kidney function labs associated with them. And then just be familiar with how the RAS works, kind of the flow of things, where the different things work. And then we talked about the next form of secondary hypertension, which is hyperaldosteronism, where now you have a condition where you have excessive amounts of aldosterone being secreted, and the most common one is you have this little tumor, this adenoma, that is producing aldosterone without any kind of feedback on its secretion. So it just continues to secrete it. It causes the same effects that aldosterone does, where it acts on the kidney to reabsorb sodium and water at the expense of dumping potassium. And because you have this unregulated dumping of potassium, you tend to get this unprovoked hypokalemia. So hypertension plus hypokalemia, be thinking of hyperaldosteronism. But to help you kind of confirm that, do a 24-hour urine aldosterone level, and then you can confirm that result by doing that aldosterone to renin ratio to help you differentiate different forms of hyperaldosteronism. Then we went on, we talked about Cushing's syndrome, which is a excess glucocorticoid condition, typically in the form of like cortisol, where you're secreting this hormone inappropriately, and it causes an increase in blood volume and renin production is ultimately the pathophysiologic effects of it. But the way that you diagnose this is you do a dexamethasone suppression test to see if those cortisol levels remain elevated, which would be an inappropriate result. And you can also do 24-hour urine cortisol levels to just check and see that the cortisol levels are high to begin with. The other thing that was interesting that we talked about with Cushing syndrome is this is the one form of hypertension where there are some physical exam findings that you can appreciate on your exam to make you suspicious for this being present in that patient. And that includes looking at like the buffalo hump. It also includes the red stria in the abdomen, easy bruisability, and even that moon facies. If you see that, be thinking of Cushing's, especially if they're having hypertension associated with it. Then we talked about the favorite of standardized tests, which is the pheochromocytoma, which is a tumor that is secreting catecholamines, and usually typical of neuroendocrine cells. And usually what will happen is this: you're not necessarily going to have elevated blood pressures all the time with this. You're only going to have it when you have that surge of those catecholamines being secreted in the blood. So typically, these folks are going to have this episodic headache, sweating, and tachycardia because you're having all those catecholamines surging. And these patients may present with hypertensive crises level blood pressure elevations, okay? And the way that we diagnose this condition is by doing a 24-hour urine catecholamine metanephrines test, which is highly sensitive and highly specific for this condition. And then we also talked about how if you suspect pheochromocytoma, you do imaging of the adrenal glands, you don't see a tumor there, that neuroendocrine tumor could be anywhere in the sympathetic chain. So you got to kind of do a more thorough evaluation if you don't see that in the adrenal glands. Then we talked about coarctation of the aorta. We talked about that in block 1, but be looking at systolic hypertension in the upper extremities, and then normal or even low blood pressure in the lower extremities, depending on how bad that coarctation narrowing is. Then we talked about some other conditions that can cause an isolated blood pressure elevation. So we talked about hyperthyroidism, and this tends to have a systolic hypertension and isolated systolic hypertension. We talked about hypothyroidism, where there's an isolated diastolic hypertension. And then we talked about hyperparathyroidism, where now you have too much calcium, and that calcium is triggering the vasoconstriction of the blood vessels, just because you have a much higher concentration of calcium than what normally should be there. Then we talked about sleep apnea that's not being treated. That can cause elevations in your blood pressure. We talked about different medications that we could be giving to our patient that can cause this, to include estrogen-containing medications. So think of a lot of our contraceptives that we give our patients. That could be causing an elevation in our patients. Could be that they're suffering from a cold and they're taking the good Sudafed that you have to ask for behind the pharmacy counter to get. Maybe that's what's causing that blood pressure to be elevated. Then we talked about alcohol, and excessive alcohol consumption can cause elevations in your blood pressure, but cocaine and amphetamines can also cause your blood pressures to elevate significantly. And then we talked about how, yes, there is a number that we're trying to treat to, but when we talk to our patients about treatment for blood pressure, we got to tell them about the consequences of not managing this condition. What are the pathophysiologic changes that could occur by having a chronic elevated blood pressure? And there's really two main limbs to this, but ultimately you're looking at heart failure, heart attacks, strokes, and affecting other organs like the retinas and the kidneys. And those are pretty serious consequences if they don't manage their blood pressure today. Then we finished this lecture by talking about hypertensive crisis, and we talked about, to be able to say a patient has hypertensive crisis, their blood pressure needs to be greater than 180, greater than or equal to 180 in systolic, and greater than or equal to 120 diastolic. And then once you have that profound elevation of their blood pressure, then we have to determine, is this hypertensive urgency, where you have that blood pressure elevation but there's no end organ damage, or are they having end organ damage and now they have hypertensive emergency associated with it? And when we talk about hypertensive urgency, the symptoms of headache, bloody nose, and faintness do not count as end organ damage or symptoms of end organ damage, okay? The symptoms that do consist of end organ damage is, if we're looking at the brain, if they start having any altered mental status, altered function like unilateral weakness and those types of things, then that's a symptom of a hypertensive emergency or end organ damage leading to hypertensive emergency. If we're looking at the heart, we're looking at hypertrophy of the structures. We're looking at ischemic chest pain, heart attack even, pulmonary edema, things that show that the heart is not functioning well because of that profound elevation in blood pressure. With the kidneys, okay, we're going to see a decline in their function. If we're looking at the vasculature, we're looking at like aortic dissections. In the eyes, we're looking at AV nicking, cotton wool spots, all these kinds of things where there is this chronic damage that's occurring to the retina itself. If you can confirm that your patient has hypertensive urgency, remember that we're not as aggressive in managing the blood pressure. Usually we want to get them down to their goal within 1 to 2 days, okay? And most of the time, we're doing this with oral medications. We're not having to do IV medications. And usually this is also done as an outpatient and not admitting the patient to the hospital. But you got to look also as to why this happened in the first place. A common thing is they were on medications, but they stopped them for one reason or another, and now they're not getting their antihypertensives, and that causes their blood pressures to become elevated significantly. If we have hypertensive emergency, where now we're having that end organ damage, Typically, the management for this is we're going to admit these patients to the ICU because we're going to have to give them IV medications in order to control their blood pressure and titrate it down. But we also have to do some pretty invasive monitoring, which cannot be done as an outpatient and cannot be done even on a regular hospital floor. It has to go to the ICU in order to monitor closely enough. And we've got a couple of agents that we could use and choose to lower. Labetalol is probably one of the most common ones that we'll use. Nitroprusside and nicardipine can also be used in lowering blood pressure. And when it comes to getting to goal, you have to know, well, what is our goal so that we know how quickly we need to lower this blood pressure. And when we talk about hypertensive emergency, remember there's these compelling conditions that would make us have to be more aggressive in managing their blood pressure. So if their blood pressure elevation is because of preeclampsia or eclampsia or pheochromocytoma, then we need to get their blood pressure less than 140 in the first hour. If it's due to an aortic dissection, we have to be even more aggressive, and we have to get them less than 120 in that first hour. Okay, so you're doing a pretty significant, profound drop in their blood pressure in 1 hour. If they don't have one of these three conditions, then we are less aggressive in lowering their blood pressure. And typically, we want to do no more than 25% in the first hour. Then if stable, get them down to 160 over 100 within the next 2 to 6 hours, and then cautiously get them down to normal over the course of the next 1 to 2 days. So you're slowly reducing. You reduce it no more than 25% in that first hour. Basically, you're just trying to lower it enough so that that stress that's causing that end organ damage goes away, and then you slowly continue then to lower their blood pressure down to the 160 within 2 to 6 hours, and then 1 to 2 days. And then aortic dissection, we said definitely want to get them less than 120 within that first hour. But when you're going to treat it, in addition to using antihypertensives to do it, there are some other agents that we should do. And the first one should be morphine, because that tearing sensation is going to cause a lot of pain, which is going to be part of the reason we are seeing that elevation of blood pressure. So if we treat the pain with morphine, we can lower that blood pressure, control their pain, and maybe that's all that we need to get them down to goal. Okay? If we give them morphine and we're treating their pain and they still are not at goal, then we can do the labetalol or esmolol in an IV titratable form to get them down to goal. But manage their pain first. If you have somebody who is coming in with hypertensive emergency and it's due to cocaine or amphetamine, IV benzos are going to be your treatment of choice, or your initial treatment of choice, okay? So treat them with benzos. If they're coming in with a heart attack, this is not one of those compelling conditions, so you don't have to be super aggressive in doing this, but you want to add nitro potentially, as long as it's not a right-sided heart attack, right? You want to add nitro, and that will cause that vasodilation, which will then take some of that stress off of the heart, and that vasodilation can lead to reducing blood pressure. That was hypertension. Any questions about hypertension? Then we moved on. We started talking about atherosclerosis and LDL, or cholesterol abnormalities. We talked about atherosclerosis. There's some things that we cannot do anything about. It just puts our patient at a high risk of having these conditions. But there are a lot of modifiable factors that we need to target to reduce risk of developing this condition in our patients. So if they have any of these risk factors, this is where the lifestyle changes could have an impact. We talked about the arterial wall is comprised of 3 main layers. The intima is the innermost layer. We talked about the media as the middle layer, which is where all your smooth muscle cells are. This is what gives you your strength. And then the adventitia is the outer layer, which is not strong, but it contains all of the supportive features to, one, provide nutrients, oxygen, and all that kind of stuff that the vessel itself needs, but it also provides all of the feedback mechanisms as well from like the sympathetic, parasympathetic nervous system. And we talked about how there's this endothelial layer over the intima, which has these antithrombic and prothrombic factors. So it regulates the formation of clots. So hopefully, clots don't form inappropriately, and this is the layer that kind of regulates that function. And we talked about how when an atherosclerotic plaque starts to form, the initial starting is this fatty streak, and then the plaque becomes more organized, more structured, and then at the end, you can get a plaque disruption, which then can cause a blood clot to form and cause potentially an acute occlusion of that vessel. But we talked about the fatty streak is the earliest visible sign that there's something going on, and typically we think of stressors that cause an endothelial dysfunction, which allows for LDL to get deposited in this space, which then initiates the immune system to react to try to clear out that LDL. And those macrophages start eating up all that LDL, but they don't have the mechanisms in place to break the LDL up, so they become so full that they actually rupture, which then leads to the release of further chemokines, cytokines, and those types of things that then causes an additional immune response and inflammatory response, making the plaque worse. But to kind of help mitigate some of this, the smooth muscle cells get recruited to kind of surround those foam cells that have ruptured to try to contain everything, and then that leads to then the lumen of the artery becoming more and more stenotic, and then that exposes that weakened wall to shear forces and other stressors that then can lead to this plaque disruption, which then causes that thrombophilic core to be exposed, and then a clot can easily form to occlude that vessel. And then this was just a cartoon version of what we just talked about, as far as the systems and processes going on leading to the atherosclerotic plaque formation. Then we talked about the different definitions of the different disorders, where if we say somebody has dyslipidemia, we mean that their LDL is high and their HDL is low. Hyperlipidemia is their LDL and triglycerides are high. If they're just hypercholesterolemia, we're just saying their total cholesterol is high. And hypertriglyceridemia just is an isolated elevation of their triglycerides. But when we look at conditions that cause elevated cholesterol levels, there's primary causes, i.e. genetic causes, and then there's secondary causes from like poor lifestyle choices and diet and those types of things. With the genetic, typically these folks are going to have, in addition to premature coronary arterial disease, they're going to have much higher elevations of their cholesterol than their counterparts who are just from poor diet kind of thing. So if you see significant elevations of LDL, be thinking of one of these familial primary causes contributing to this. And then these were just causes of secondary causes of hyperlipidemia. But we talked about how, especially in your primary causes, you may actually have some physical exam findings that would make you suspicious of elevated cholesterol. And we talked about how you can get these xanthomas, which there's three main types. There's these eruptive xanthomas, which typically affects like the buttocks, the back, or the extensor surfaces of the extremities, where it almost looks like acne, but you don't see that inflammatory response. And these are not whiteheads, these are actually yellow, so they look different from acne. Then you have your tendinous xanthomas, which tends to affect like the Achilles and the extensors of the hands, where you get these firm kind of nodules that develop in those areas. and that's actually just cholesterol deposition. Then we talk about tuberous xanthomas, and these are common on the like the elbows and the knees. And then xanthelasma, which is this yellow growth on the eyelids that you see in this picture here. That's actually cholesterol deposition. And then we talk about how you can get LDL cholesterol deposition in the cornea itself, and that can lead to this yellowish ring around the eyeball, and that is lipid. Don't confuse this corneal arcus with Wilson's disease or the Kaiser-Fleischer rings, which is a copper deposition in the cornea. When you go to diagnose a patient, you're going to get fasting lipids because you want to see what their cholesterol actually is. And then you also want to get things like looking at their liver function, renal function, what's their diabetes level, because that's going to help me decide on risk. And then I wanted to get a baseline creatinine kinase because if I'm going to give them a statin, I need to know what their baseline is first because statin could affect that value. But when it comes to the treatment, your lifestyle changes could have enough of an impact. So eating healthy, exercising, all of those things can lower your LDL levels, and they can raise your good cholesterol, your HDL levels. But when the patient does require medications, their statins are going to be our first-line agent because there is mortality benefit associated with it. It can also reduce stroke risk and other things. And, oh, by the way, it's the best oral medications that we have on the market to lower LDL levels. But there are side effects that you got to be aware of. So you got to be worried about the muscle problems, which could range from anything from muscle aches like myalgia, but it could be myopathy where the muscle pain is worse. And you have an elevation in the serum creatinine kinase levels higher than normal, but they're not as profound of an elevation as you would get in like rhabdomyolysis. So myopathy is a less severe form of rhabdo in that creatinine kinase elevation. And when you get these patients who come in with these muscle concerns or complaints, stop the statin, work them up for rhabdo, and then determine if they would benefit by being restarted on a lower dose of the statin, or changing the statin entirely, or discontinuing statins altogether. Yeah, and that's just what we talked about right there. But then when it comes to statin treatment, you've got to know what medications and what dosages give you the different intensities, because when you're reading the guidelines, it's going to say high intensity, moderate intensity, low intensity doesn't really talk about it. But knowing which dosages of the medications will give you those things is important, so that you can pick the right medication and dosage to meet the requirement for management. And then in addition to statins, we talked about ezetimibe or Zetia, where this is typically used in conjunction with statins, where the LDL goal isn't met with just that statin itself. So you can add ezetimibe, and that works good as an adjunctive therapy to lower cholesterol. It doesn't necessarily work the greatest as a monotherapy, but it does work as a good adjunctive therapy. And then for our patients who either cannot tolerate statins or they're not getting the goal despite being on statin and ezetimibe, then you have your PCSK9 inhibitors like Repatha, and these work great at lowering your LDL levels. And they usually are pretty well tolerated, but they are so expensive that these are not our first-line agents yet. And then when we went and started talking about treatment, we had to talk about what's primary prevention and what's secondary prevention and what those definitions are. Because when I look at the algorithm, I'm going to have to go down one arm or the other, depending on if this is secondary prevention and primary prevention. And remember, I'm going to give you this exact form during the test for your reference to answer questions based on cholesterol management. But be familiar with how this algorithm works. Be careful of the caveats or the additional information that might alter what your goal is or what the appropriate medication should be, depending on the case that I give you on the test. We talked about some risk enhancers or things that might make somebody a higher risk that you may want to be a little more aggressive in managing their cholesterol. And we talked about how metabolic syndrome is one of those things where you have to have at least 3 of the 5 criteria in order to be officially diagnosed with metabolic syndrome. But there's other things that can put somebody at a higher risk of their cholesterol that they would benefit from being on treatment or being at a higher dosage for the treatment. And then we also talked about, from a secondary prevention standpoint, you have to differentiate what a stable ASCVD patient is versus a very high-risk patient. And the way that you do that is by looking at if they have 2 or more of these, or if they have 1 of these and at least 2 of these, then that would put them at a very high-risk patient and would benefit from being treated much more aggressively with their cholesterol. Then we finished up this lecture talking about hypertriglyceridemia. We talked about how if you have just moderate elevations, we usually don't treat this with medication. We usually just do lifestyle choices. It's only until the triglyceride gets greater than or equal to 500 that we actually are giving medications to treat the triglyceride levels. And there's a number of different things that we can do in order to treat this, to include our fibrates, which is the best agents to lower triglycerides. Gemfibrozol is better than fenofibrate at doing it, but gemfibrozol carries that increased risk of rhabdo if the patient is on a statin as well. So if you have a patient who's on statin for LDL management but needs to be on a medication for triglycerides, then you are stuck with just using the fenofibrate, which will work. It just won't work as well as gemfibrozol will. Niacin is another option. The problem with this is just poor tolerance to the side effects associated with the dosage necessary to actually have any kind of impact. Omega-3s, we're not sure how they work, but that can have an impact on lowering your triglyceride levels as well. And then we talked about metabolic syndrome again. And then we went on and talked about ischemic heart disease, which really brings us to our 50 minutes. So let's take 10 minutes. We'll come back.
I just looked at this section I missed and I was like, shit, that's kind of a...
So let's hear about.
What is that? Oh, you're on the...
Have them all doubled up. Just search statin.
Nobody cares about that AR. Yeah. Get rid of all those except for AR.
I'll just do this. Yeah, you showed me this.
Oh, the cut thing?
And then I'll do that's it. And then I'll just blow it all out. So I don't even look at it.
It's a lot of work.
Yeah, then you'll never look at it. He doesn't care about this one.
Well, I know he cares about it.
Or that one.
I just don't like it.
Never give Simmons that.
But that's the only time I've heard him use a cuss word, so I figure it's like that. What about stuff with this? Okay.
Just he said the biggest ones that lower stuff.
That's saturated.
Just these three and then the 50/20.
That one. The 60/20. Whatever.
Yeah.
Uh,
I want to sleep back there.
that's fine. I want to
Angry
bathroom.
Birds.
I want to bathroom. No, I'm on Angry Birds for sure. Which one? That one. HMG. Okay.
But yeah. There isn't a
Whatever. That one. That was okay. That's fine. Thank you.
I can send my
No,
slim
dude,
down.
everything else has been pretty marked up so far.
Whether I get information or not, it's based on scenario. I feel like it's house.
You become wiser.
Tired man. That's sight, not in there. Hot, cold. Yeah, but by the time I get to that, I've already asked that sight. Double, like, then when I'm kind of like, I already asked that. And then like, when I'm ready to go down, you know, hot, cold, on. Because fatigue can take. So I just added it on. I like that date that he gave you. So you get like some things do this, and I'm probably gonna use it. You can always ask. Yeah. So I'm saying even if it don't.
I know, right? And I would like type the question. Rate it on a scale of 1 to 10. Such a sad status with the status of what is it? Marley and me? Oh, dude. Dry every time.
Putting him on a time crunch, give a timeline. Deep time.
Tomorrow morning, but I didn't say
I'm
like this week.
I thought about it too. It was like straightforward.
I didn't submit it on Canvas. Yeah.
Submit it on Canvas?
No,
Oh, okay.
I emailed it to him, but through Canvas.
Oh, okay. I was gonna
I
say
don't
like,
know his problem, you know.
I was gonna say like, he doesn't want it from us yet. He doesn't want it from us yet.
He doesn't want it.
He told us he'll ask us for when he wants it.
I just wanted to see because I've never done it.
Which is fine. See, you only really wanted us to just do the. That was the whole point. Like that last one we did, he said what he cared about was us
we're doing a new one every time.
getting good rejected.
That's what
Not
those
even
papers that
putting
way.
the whole diagnosis.
Yeah, but that's
Excel.
when we submitted. That last one we did was not an actual like full recipe. That was just he wanted us to go through the motions.
Get back to our seats and pick up where we left off. See that I need to pick up the speed a little bit.
Whoa.
Okay. All right. So we finished talking about hypertension. We finished talking about LDLs. Let's now start looking at the consequences of having either one of those conditions and what it's going to do to your blood vessels, regardless of it, whether it's in the heart or if it's your peripheral arteries, your aorta, or even your veins. So we talked about when we're looking at coronary arteries themselves. It's not a situation where you just get a little bit of stenosis, you're going to start to have problems. It does take a significant amount of stenosis to even start bringing on symptoms, okay? So usually we expect at least a 70% stenosis before symptoms with exertion come on. So 70% symptoms with exertion. And it's not until you get about 90% or greater stenosis that you start to get symptoms at rest. Okay. And we talked about how there's this this kind of the seesaw of your oxygen supply and your oxygen demand, and the goal is for the coronary arteries to at least meet that demand so you don't start to develop ischemia and having to develop like an aerobic metabolism. And we talked about the things that can affect your oxygen supply are, well, one, how much oxygen is in your blood in the first place. And we talked about how this usually is something that's tightly regulated unless you have some kind of pulmonary disease that limits your oxygen-carbon dioxide exchange. But then we talked about how really the main thing that impacts supply is your coronary artery blood flow. And there's multiple variables that kind of go into affecting how much blood is being perfused through the coronary arteries. The first one is, well, what's the pressure of perfusion? Remember, these arteries are perfused during diastole, not systole. So what is that diastolic pressure? Is it adequate enough to perfuse the myocardium? Then we talked about the coronary vascular resistance. So is this a constricted coronary artery or is this a dilated coronary artery? Is it allowing easy flow through the artery? And there's a number of things that can impact that resistance. It could be external compression from like the myocardium squeezing, limiting that blood flow through that area. But there's all these other feedback kind of mechanisms that could also alter and affect the coronary artery perfusion, to include your like sympathetic parasympathetic system, but even other like endothelial factors and metabolic factors that can impact that flow or that resistance in that coronary artery. When we talk about oxygen demand, there's really three main things that we think about. So ventricular wall stress, so how much exertion, how much energy is the myocytes having to exert just to maintain that contact with their neighbor. If they have a higher stress, they're having to work harder to maintain that contact. Heart rate, so the faster your heart's beating, the more oxygen it's going to need. And then the more powerful the squeeze, that's going to increase the demand. So those are really kind of our three factors in addressing oxygen demand to help prevent ischemia and infarcts. But there's lots of different pathologies out there that can affect these two factors in regulating the amount of oxygen and nutrients getting to the cells in the heart. So from a supply standpoint, okay, if you start getting atherosclerotic plaque formations, that can limit that supply through that vessel. The endothelial dysfunctions, spasms, and those types of things can cause alterations in the supply. But we talked about the reason that there is concern and why damage occurs with reduced oxygen states is you get that switch from an aerobic metabolism into an anaerobic metabolism, and that causes the production of all these toxic things like free radicals and all those types of things. And those compounds can then limit the function of the cells themselves. And then there's a couple of different definitions that we talked about. We talked about stunned myocardium, which this is in a setting where you have this acute but severe and transient ischemia, where the blood flow is significantly impacted all of a sudden, and then it gets better, and those cells didn't die, but they are not functioning right away. It takes some time for them to start functioning again. They're stunned. Okay. Then you have hibernating myocardium, which this is a state of persistent impaired myocardial function due to a chronic decreased perfusion. But the amount of blood perfusing, the amount of oxygen, the amount of nutrients that are getting to those cells is enough to keep them alive at rest, but not enough to allow them to function. And when we do procedures to kind of improve blood flow, these are the cells that we're specifically targeting in order to get them what they need in order to start functioning again and to restore cardiac function. Then we talked about variant or Prinzmetal angina, which is due to a coronary artery spasm. And there's lots of different things that can cause this spasm to include like cocaine use or endothelial dysfunction, smoking, whatever. And these patients, they're going to come in with that ischemic chest pain. They're going to come in with those the EKG changes to suggest a STEMI, but it's not a true STEMI. But when you have somebody who has this condition, in the acute setting, we're giving them sublingual nitro to kind of dilate those vessels, stop the spasm. But in order to prevent these episodes from recurring, you can give them the calcium channel blockers, like your PEEN medications, your dihydropyridine medications, to prevent that spasm from happening in the first place. Then we talked about silent ischemia, where this one's going to be a difficult one to diagnose and manage because you may not know that this is going on because they're not having the typical pain, the typical chest pain associated with this. So they may not come in until it's too late. And risk factors for this include your diabetics who already have other peripheral neuropathies, your elderly patients, and then females are more at risk of having silent ischemia than their male counterparts. And if you have a patient who you are suspicious may be having this going on, the way to diagnose this is make them exert themselves, see if you can find any ST changes that occur from this, and or do some cardiac enzyme testing to see if they're leaking any troponins into the blood because of that ischemia. And then when we talked about angina, there's this spectrum of disease where you have stable angina on one side, and then you have your acute coronary syndromes on the other side. And what helps differentiate these two sides is simply this plaque rupture that occurs, okay? So in stable angina, you don't have this plaque rupture. Once that plaque ruptures, that pushes you over the edge, and now you're in this acute coronary syndrome. And with stable angina, typically they're going to have at least a 70% obstruction or stenosis of the vessel. And so that means they're going to have this pattern of predictable chest pain with exertion. Okay. So normally there's something, exertion, or maybe they ate a large meal or something like that that triggers these episodes to come on. Typically once they stop doing whatever that trigger was, the pain will go away within minutes. If you wanted to give them sublingual nitro, that would just make it go away even faster. Okay? But usually we're only talking about minutes, especially after removing the trigger. But then we also talked about how the pain that you have with chest pain is not the stabbing pain that we normally think about. It's usually these vague kind of terms of like a pressure, a tightness, elephant sitting on my chest. Those types of descriptions are used for cardiac chest pain. And then we talk about anginal equivalents. So these are symptoms that the patient may have in addition to chest pain, or maybe these are the only symptoms that they're having. So for instance, if they're having silent ischemia, maybe having these symptoms are going to be what would make you suspicious that something cardiac is going on. And these anginal equivalents are brought on by the sympathetic parasympathetic nervous systems kind of working to try to fix the problem. So what ends up happening is you may notice this unprovoked tachycardia. They may have sweating or diaphoresis when they haven't been working out or anything like that. They may feel nauseated or even vomiting because of that. And then you may start to notice some symptoms associated with decreased cardiac function. Your EKG in stable angina, most of the time could be completely normal and won't have any abnormalities with it. If it does have some abnormalities, they're kind of non-specific kind of changes that are typically only there when there is pain. You can and should do labs, and you're going to look for troponins and stuff like that, but understand that that is going to be normal in stable angina. You're not going to have elevated troponins in stable angina. So what do you do when you have a patient who you suspect has stable angina? If they're low risk, then put them on, if they're intermediate risk, put them on, get some kind of stress test in order to challenge them to see if you start to see some changes or if they start to develop symptoms with it. If they're high risk, then usually we're just bringing those patients back to get like PCI or CABG done just because of their high risk standing. But then we went and we started talking about the treatment for stable angina. Then we talked about how you have the acute treatment and then you have the chronic kind of daily treatments that you need to do. In the acute management, typically you're going to have them stop doing whatever was the trigger for that pain episode, and then you're going to give them typically sublingual nitro to cause that vasodilation, improve that supply to address the demand problem that's going on. But when we start to think about the chronic management, kind of our goals for this are, let's decrease how frequent they have these pain episodes in the first place. Let's prevent them from developing, from this condition progressing and developing one of the acute coronary syndromes. And then ultimately, let's get them, let's improve their survival, let's improve their functional and quality of life. And this is going to entail lifestyle changes, so the things that set them up to be at risk of developing this condition, we need to treat those things, get them moving, control their other conditions that put them at risk for this. But when we talk about the two different management, the other two different managements, so prevention of recurrent attacks and the prevention of acute coronary syndromes, there's specific medications that we're going to give them to achieve these goals. So to prevent the acute episode from happening, so that stable angina pain from happening, first thing you want to do is put them on a beta blocker and titrate the dose if you can so that their heart rate's between 55 and 60, okay? This is first line because it has a mortality benefit associated with it, okay? And there's a couple of different options out there, metoprolol or atenolol, that work great. But you got to be careful of who you give a beta blocker to. So if they already have a heart rate that's lower than goal, probably not the person that you want to be putting on a beta blocker. If they have some kind of heart block, that's just going to make it worse. So please don't give it to those patients. Calcium channel blockers are second line, but typically because these do not have the mortality benefit like the beta blockers do, we only give calcium channel blockers to patients who either can't tolerate the beta blocker for one reason or another, or you have them at max dose of that beta blocker and they still have their heart rate higher than goal. So if we still have, heart rate of 65 or so, we're not at goal yet, maybe they would benefit from having that calcium channel blocker on top of the beta blocker they already are on. Next thing you can do is give them nitrates, and this is not the sublingual nitrates that you use in the acute setting. This is going to be something that is more of a long-term, longer-acting or longer-lasting medication. And so you've got like oral and dermal preparations, so pills or like topical creams that you can put on, and that will give you a longer-acting version of this. And then the last one is ranolazine, which is a sodium channel blocker, and this works great in conjunction with the nitrates and in conjunction with the beta blockers, and it decreases the frequency of anginal episodes and improves exercise capacity. So that's the treatment for preventing recurrent stable angina attacks. Counsel the patient, all of your patients with chronic medical conditions about compliance, sticking with the treatment plan, and then what else could you do to prevent additional stressors on the body? So annual flu vaccine to prevent contracting flu, preventing fevers, and those types of things. Then we talked about prevent the acute coronary syndrome, so preventing them from progressing. And one of the things that separates acute coronary syndromes from stable angina is that plaque rupture that leads to that acute clot formation. So let me prevent that clot from forming by giving them antiplatelet therapy. And that could be done with your aspirin or clopidogrel, depending on if they're aspirin sensitive or not. The other thing that you can do to prevent them from having that plaque rupture is by putting them on a statin. Statins have been shown to stabilize plaques, so they are much less at risk of having rupture occur. For your diabetics, put them on a GLP-1 or SGLT2 inhibitor. Those have been shown to improve cardiac mortality in these types of patients. And then even ACE inhibitors, because it can, one, control blood pressure and reduce afterload, but they do have a mortality benefit associated with them as well. But some of your patients may not respond to medications, or if they are high risk, then they may need to be a little more aggressive in treatment for their condition. And when it comes to like the revascularization procedures, we have two main options. So we have percutaneous coronary intervention, PCI, which includes putting like cardiac stents in place, or we have coronary artery bypass grafting for those that are higher risk in restoring blood flow. PCI, you've got a couple of options in the stents that we talked about. We talked about how PCI is super successful, especially in your higher risk patients. And the use of stents has improved outcomes associated with it. However, when it comes to stents, we have two options. We have the bare metal stent, which does have improved function, but there is a higher risk of restenosis because the body starts to kind of grow cells around that metal cage, and that can cause a restenosis of the vessel. So in order to prevent that, they came up with the drug-eluting stent, which has a medication in it that prevents those cells from forming around the cage for an extended period of time, and that reduces the risk of restenosis. The problem, though, is because you don't have that scar tissue forming around the stent, it means that platelets can become activated and form clots on that foreign body, so you need to be on dual antiplatelet therapy for at least 6 to 12 months if the patient got a drug-eluting stent placed. And then there are some people who would benefit from the CABG procedure, which there's a couple of different versions to that, but there are indications still to this day. Even though you have a great success rate with PCI, there are certain patients who would benefit by doing a CABG. And then we finish this conversation by talking about the reason we don't skip the medication therapies and go straight to revascularization is the COURAGE trial that was conducted showed that there actually is no significant difference in long-term outcomes in the medication-controlled group and the early revascularization group. So folks tend to do just as well with medication therapy as they do with early aggressive revascularization. Then we went on, we talked about acute coronary syndromes, and we talked about how now you have that plaque rupture, and now you can have either one of two categories of acute coronaries. You can have your non-ST elevation acute coronary syndrome, and then you can have your ST elevation MI. And what kind of differentiates these two is you tend to have a partial occlusion, so greater than 90%, but there's still a little bit of blood flow kind of getting through, versus a STEMI where you have a total occlusion, so you have 100% occlusion of blood going through. And then the other thing that was important to kind of highlight is the EKG changes that you get with both sides. So STEMI, okay, you're going to have that ST elevation, that makes sense. With an NSTEMI and unstable angina, you can have that ST depression or those flipped T waves, and those are indicative of one of those. But what kind of really distinguishes the unstable angina from the NSTEMI is what those biomarkers are doing. In a NSTEMI, those biomarkers, so the troponins, will become positive. In unstable angina, the biomarkers, the troponins, will remain negative. And we talked about how when it comes to a STEMI, depending on where you're seeing that ST elevation can help you differentiate and determine where exactly is this lesion in the coronary artery that's impacted. So if we have a septal or anterior, we're looking at the left anterior descending artery. If we have like an inferior, we're looking at the right coronary artery. And if we have a lateral, we're looking at the circumflex artery, although there is some left anterior descending components to that as well, but we're thinking of the lateral MI as being more of a circumflex artery problem. And just remember when you take your chest pain history, your OPQRST, because that can help you differentiate the different types of cardiac chest pain versus non-cardiac forms of chest pain. And then we talked about how blood testing, like your troponins, are going to be important. If you have a patient coming in with chest pain and that initial troponin is negative, you can't just dismiss them at that point. You've got to repeat that troponin because it could be that you just took that test too early and you haven't started to see that rise of your troponin yet. ST depressions and T-wave inversions, typically indicative of subendocardial ischemia, so it's a very focal area that's under stress because it's not getting the oxygen and nutrients that it needs. When we talk about ST elevation, the full thickness of the muscle in that area is impacted, okay? So you have a much more broad, more serious impact from that, that ischemia that's occurring. And to be able to say that this patient has an ST elevation, you one have to identify, well, where's the J point? And then you got to compare that to the baseline of the EKG to see if it's elevated. And once you've determined that, to be able to say that this is an ST elevation, you need at least a 1 millimeter or 0.1 millivolt increase in 2 contiguous leads, unless it's V2, V3, where you get a little more of a cutoff depending on if you have a male patient or a female patient. And then we talked about Q waves and how this is more indicative of a prior heart attack because these are not something that develop in the acute setting. It takes hours for these Q waves to develop, and just knowing the criteria for Q waves will be important. Unstable angina, we talked about how you get that partial occlusion. EKG can have those T-wave inversions and T-wave, flipped T-waves, but the troponins are always normal. And then STEMI, you can get, again, a partial occlusion. You may have those T-wave inversions and ST depressions on your EKG, but your troponins are elevated. And then STEMI is that transmural ischemia, and you get those ST elevations that are localized to a certain coronary artery. And we talked about how with the heart attack or with that ischemia that's going on, there are some negative consequences that can develop from the loss of function. And it can include things that affect the function of the heart, leading to pulmonary congestion and those types of things, or the muscles that control the mitral valve or the tricuspid valve become damaged, and now you start to get like a regurgitation, and think of the additional stressors that are going to be added to an already diseased heart with that condition. But then we talked about if you have a patient with acute coronary syndromes, there's an algorithm on what you need to do, and part of that algorithm is some of the time hacks that are required to get things done in order to optimize the treatment for your patient. So in the pre-hospital setting, we try to get aspirin as soon as possible. Get an EKG so we can see if this is a true STEMI or not, and then we need to get them to the hospital as soon as possible. And once they get to the hospital, they have to identify if it's a STEMI or not and activate the team that's going to help take care of them. They're going to give them oxygen if oxygen levels are less than 90% room air. They're going to get blood. They're going to do some history kind of things. They're going to do some physical exams. But then they have to figure out, can they get this patient up to a cath lab or not? Because if they can determine that this is a patient who is having that ST elevation, then they have to get that patient to the cath lab within 90 minutes of them coming to the door, okay? So 90 minutes, if you're in a facility that can do PCI, 90 minutes within their first contact, they need to get it up there. If you have to transfer them, then you get an extra 30 minutes to coordinate that transfer. So you have 2 hours basically. But if you cannot meet those two time hacks, then you have to do fibrinolytic therapy with like TPA. And the goal is within 30 minutes of that first contact, they're getting TPA administered. If they're not having an ST elevation MI, and they're having one of the non-ST elevation acute coronary syndromes, you have to do that risk assessment to kind of validate and see which category they fall into. Because if they're low or intermediate risk, you may be able to discharge them to home without patient follow-up. Probably want to get cardiology on board just to make sure that that's the appropriate thing. But there is a possibility that they can do outpatient if they're low or intermediate risk. If they're high risk, then we typically are doing early invasive therapies. So they're going and getting PCI done. They may be being put on dual antiplatelet therapies to prevent that complete occlusion of the vessel itself. When we talked about the risk assessment, we talked about the heart score, and we talked about how I don't want you to memorize each factor that goes into this. I just want you to know that depending on the score that you're given is going to determine what their risk is. So on a test question, I might say they have a low risk heart score, or a moderate or intermediate risk heart score, or high risk heart score, just so that you can know which category of risk this patient is going to be put into. Then we talked about the TIMI score, and again, I don't want you memorizing all the components to it, but the TIMI score is used to estimate what is their mortality rate in the next 14 days. And the higher the number you get, the increased risk that you have with those patients. So if they have like a score of greater than 6, you're talking about there's a 41% risk that they're going to die in the next 2 weeks from their cardiac condition. And then we talked about the medications for for treatment of acute coronary syndromes. We talked about the antithrombic therapies, so your antiplatelets. Aspirin is kind of your mainstay. If they have aspirin sensitivity, then you can do clopidogrel. And then we also talked about how if they do undergo a PCI and they do get cardiac stenting in place, they may need to be on dual antiplatelet therapies, depending on which version they get. If they got the bare metal stent, then you're looking at about 1 month of dual antiplatelet therapies. If they got the drug-eluting stent, they're going to need the much longer version of that, so they're going to need at least 6 to 12 months of being on dual antiplatelet therapies. Once they finish that period of time, then typically we'll stop like the clopidogrel and put them on just aspirin daily thereafter. We also talked about the fibrinolytic therapy, so things like TPA. If you can't get them to a PCI capable facility or get them into the PCI lab within that time hack, then you're thinking of giving them fibrinolytic therapy to break up that clot. And this is usually only in the setting of a STEMI, okay? Not indicated for unstable angina or NSTEMI. And once you give this patient fibrinolytic therapies, they are not out of the woods, okay? You're not done with their treatment. They still need to go to a hospital to have a cath lab done, or to get a cath procedure done, because they still have the problem that triggered this acute occlusion there. They need to get that cardiac stenting placed or get that CABG procedure done in order to address that perfusion deficit, that perfusion problem that triggered the acute coronary syndrome. Anti-ischemic therapies, so nitroglycerin, I think we've talked about that extensively. Beta blockers, they reduce the post-MI cardiac remodeling. They carry a mortality benefit with them that the calcium channel blockers do not carry with them. So that's why beta blockers are always first line in this setting. ACE inhibitors also reduce adverse remodeling, so they have a mortality benefit associated with them. Statins stabilize those plaques so that you're less likely to have recurrence of that acute occlusion. And then I think we've talked about left heart cath and PCI enough. We need to know what those time hacks are. And then, again, coronary artery bypass grafting is an option for us. But there are complications that you need to be on the lookout for. Once you've treated their heart attack, they're not out of the woods yet because there is some damage that did occur from that, and you got to be on the lookout that they may experience some further ongoing issues. So one of them is recurrent ischemia, especially if they didn't get like a PCI done or a CABG done. They're at risk of having recurrence of that chest pain. Arrhythmias is also a concern because depending on which area is affected, it may damage important structures in the conduction pathway, which then can lead to those arrhythmias developing. Depending on how much of the myocardium is affected by this, you may start to see decreased function of it, which could lead to heart failure. And then we talk about cardiogenic shock, which typically comes from a decreased contractility that then leads to hypotension, which is defined as systolic blood pressures less than 90. That hypotension then leads to reduction in coronary artery perfusion, which then means we're having ischemia, which then is impacting the function, and it's just the spiral of death. So you can imagine somebody experiencing cardiogenic shock is going to have a pretty high mortality rate associated with it. Right ventricular failure, the kind of the big thing to be on the lookout for is if you have somebody who's suffering from this, don't give them nitrates or morphine. You can have a papillary muscle rupture if that ischemia is affecting the muscle. It can lead to that rupture, which then leads to the chordae tendineae attached to the valve leaflet just kind of flapping in the breeze, and you can get regurgitation develop acutely. Then there's the ventricular free wall rupture, so you have an area that's damaged or dead, necrotic from that ischemic event, and that can lead to a weakening of the wall, which then leads to a high risk of that rupturing, which then leads to bleeding out, cardiac tamponade, and those types of things. But instead of the free wall rupturing, what happens if the ventricular septum ruptures? Okay, so the area is just the area that's impacted is just different, and now you have the connection between the left and the right ventricle is made, and now you start to have oxygenated blood gaining access to the right ventricle, and now that can lead to all those pathophysiologic things that we talked about in the last block. Then we talk about how you have an aneurysm that develops, so a weakness in the wall because of that ischemia. And then we talk about the inflammatory condition of pericarditis that can happen after the heart attack, and how there's the acute pericarditis, which happens within 2 weeks, or the Dressler syndrome, which happens greater than 2 weeks from the MI. And it's important to be able to differentiate these things because you want to avoid ibuprofen and endomethacin or other NSAIDs because that can affect the scar tissue formation and put the patient at a much higher risk of having a free wall rupture. And then the last complication that we talked about was thromboembolism, so the formation of clots. If an area is impacted by a heart attack and it stops functioning, you start having stasis of blood in that area, and then that can form a clot, which then if that clot gains access to an area that is flowing, then it can get sent downstream and impact things like your brain, causing a stroke, or your mesenteric arteries or other peripheral arteries, and impacting the flow of blood to those organs. Then we went on, we started talking about peripheral arterial disease. We talked about the aorta initially. We talked about how a true aneurysm of the aorta has a dilation of all three layers of the artery, so it tends to be a little little stronger because it has all three layers, compared to a pseudoaneurysm, which is usually the adventitia is intact, but there's a tear in the media and the intima. And when we talk about aortic aneurysms, when we talk about aortic aneurysms, we talk about how abdominal aortic aneurysms are much more common than even the thoracic aortic aneurysms. And when you have an abdominal aortic aneurysm or a triple A, then be thinking of atherosclerosis and other risk factors for atherosclerotic disease as the risk factors for developing this condition. And we talked about how our patients with this are going to most commonly be completely asymptomatic and have no idea that there's anything wrong. They may have just vague kind of pain, but if that were to rupture, then they could come in with pretty severe symptoms, mortality, those kinds of things, because the abdomen can hold quite a large volume of blood before it's tamponaded and the bleeding stops. So you can lose a lot of blood in the abdominal compartment. On exam, you may appreciate a pulsatile abdominal mass, but this is not something that you should rely on because it's all going to depend on body habitus of the patient, your ability to detect it, and everything like that. So identify those folks at risk and screen properly. And the way you would evaluate this patient is abdominal ultrasound is the imaging test of choice, especially if they're unstable. You can do it there in the ER, diagnose it, and then get them up to the OR to get this thing fixed. It's highly accurate. If you have a hemodynamically stable patient, you could do a CT scan. But the USPSTF does have screening recommendations for this, and this screening is one-time screening for US males aged 65 to 75 with any smoking history. Okay, that is the absolute folks who need to be screened according to the USPSTF recommendations. The other four choices, there's not great screening recommendations for those categories of patients. Then we talk about thoracic aortic aneurysms. We talked about how these are much less common, but instead of this being a disease associated with like atherosclerosis, this is now a disease that's associated with connective tissue diseases like Marfan's, Ehlers-Danlos, and those types of things that cause a weakness of the medial layer of the artery. So the strong layer of the artery is impacted by this disease. And we talked about how these tend to be asymptomatic, but you may have symptoms presenting with symptoms associated with compression of other structures from this aneurysm. So if they're having hoarseness, it could be the recurrent laryngeal nerve is being compressed. If they're having coughing or hiccups or something like that, it could be the phrenic nerve that's impacted by it. We talked about how, chest x-ray, you may see some abnormalities on it, but your echo is going to be your test of choice because it's the most sensitive and most specific for diagnosing this condition. And when you have a patient who is diagnosed with aortic aneurysm, you want to be aggressive at limiting or treating their blood pressure. So typically we're thinking of trying to get their blood pressures less than 120/60. ARBs is definitely an important thing because ARBs have the effect on like the TNF alpha to limit that growth. And then we talked about how you need to do that ultrasound so that you can kind of assess who would benefit from surgery and who would benefit from monitoring. And so typically we're doing a repeat ultrasound every 6 to 12 months if somebody has an aortic aneurysm, whether that be thoracic or abdominal. And usually in a normal patient, once that gets above 5.5 centimeters, then we are doing surgery. If they have Marfan's, because of the higher risk of rupture, they have greater than 5 centimeters, they're getting surgery. If they have Lloyd-Dietz, then it's greater than 4.5, just because those folks are at a much higher risk of rupture, even at a smaller dilation. The other indication for surgery is if that growth in the course of that 12-month period of time is greater than 1 centimeter, then they are getting surgery because of that rapid growth puts them at high risk of rupture. And the way that we fix it is either we can do a grafting procedure where we remove the diseased part and replace it, or we can go through catheters through the vessel and do an endovascular procedure, which is a less invasive approach to fix the problem. Then we talked about aortic dissections, and we talked about how these are rare, and there's several ways that this could develop to include blunt chest trauma, or we did the damage when we were doing a procedure, like a catheterization procedure, that caused that rupture or that tear to occur in the intima. And we talked about how it's important to classify these patients correctly because that's going to impact the treatment. If we had a type A, which is if it involves any portion that is proximal to the left subclavian, then that's a type A Stanford classification. If it is all localized distal to the left subclavian, then this is a type B Stanford classification aortic dissection. And these patients are going to complain of like this tearing or ripping sensation, and depending on if it's a type A or B is going to kind of depend on where that sensation is detected. But the other kind of presenting signs that you need to be worried about is what happens if that tearing starts to affect some of the major branches off of the aorta in that area. So it could be that they come in with stroke-like symptoms. It could be kidney dysfunction, or other major concerns. And with this, usually you're going to have things like asymmetric blood pressures in the upper extremities, hypertension. They may even have altered mental status and other, presenting a severe condition, depending on how bad that dissection is. And we talked about how if we have a stable patient that we suspect has a dissection, we're going to try to do a transesophageal echo. However, if we have an unstable patient, then we are doing a chest CT scan. In this case, the reason we are putting an unstable patient in the CT scanner is I need to know exactly where that tear is, so when I crack their chest open to try to fix the problem, I know exactly where I need to go, instead of me trying to figure out where to go and where to cut. So chest CT in your unstable patients with aortic dissection. Other things may not be as useful, but you may have some findings associated with them. But with an aortic dissection, you're going to admit them, you're going to start controlling their pain with morphine, and you're going to lower their blood pressure. You have to be aggressive in lowering their blood pressure because you want to stop that tearing that's occurring. And then, depending on which type of dissection you have, whether it be type A, Stanford classification type A, or Stanford classification type B, determines what your treatment is, okay? If it's type A, they're going back to the OR right now. If it's type B, and they're not having any other problems associated with that tear, then we can manage those with medications alone. And the reason we have that difference between treatments is the mortality rate of somebody with a type A is 25% for getting surgery done. But if we don't treat them with surgery, and we try to treat them just medically, they carry a 60% mortality rate. So you have a much higher mortality rate with medical therapy in a type A. Compare that to type B, where now, if I treat them with surgery, they have the same mortality risk, but when I try to treat them medically, that risk is much, much lower than it is even in the surgery group. So now that risk-benefit ratio is very different, and now it tends to doing medical management for them. Then we went on, we started talking about peripheral atherosclerotic disease, and we talked about the risks for this, or the things that put somebody at risk of developing atherosclerotic disease in the first place, right? We talked about how some of these patients, most of these patients are going to be asymptomatic, have no idea that this is going on. But once it starts to get bad enough, that stenosis starts to get bad enough, it starts to affect the blood flow to the area, the oxygen delivery in the area, and they may start to get that intermittent claudication, which is this pattern of predictable symptoms with exertion. Okay. And then as that progresses, it then can develop into critical limb ischemia, where things are dying, and that's a really serious finding. So what else can you find on your physical exam in your patients with this disease? So you may start to see some chronic changes like skin changes, hair loss, nail thinning because it's just not getting the oxygenation and nutrients that it needs. You may start to get these ulcerations developing because of that reduced blood flow. But then you can get dry gangrene, which is that black discoloration without the exudates, and you can get wet gangrene, which is similar to a STEMI, where you get exudates in addition to that black discoloration. And we talked about how, think of claudication as the equivalent of stable angina. It's that pattern of predictable exertion brings on symptoms. If I stop my exertion, the pain tends to go away within a couple of minutes. If I start to develop pain at rest in that, then that means that this has progressed. And we talked about the way you diagnose this, or one of the ways you diagnose this is you do the ankle brachial index, where you're taking the blood pressure of the upper extremity and comparing that to the lower extremity, and then you get your ratio. And knowing, okay, if I have a ratio of less than or equal to 0.9, this is indicative of peripheral arterial disease. If it's greater than 1.31, then that also is a concern for peripheral arterial disease. If I'm in the 0.91 to 0.99, this is borderline. If it's 1 to 1.3, then that's normal. And the way we treat this is first exercise therapy. You want to get those folks exercising. The exercising pushes them to their limits. It encourages collateral circulation, so you have new blood vessels that start to form to try to get good blood flow to the area that's impacted. But to help improve function, silostazol can also be used to help with their symptoms. And this is good because it increases walking distance, so they're able to exert themselves even more, encouraging those additional blood vessels to form. They should be on aspirin therapy. If they can't tolerate aspirin, then clopidogrel is actually indicated for the treatment of peripheral arterial disease, because you're basically trying to prevent that development of acute limb ischemia. If they do need to get surgery for this because they're not responding to the conservative treatments, the exercise therapy and all that kind of stuff, then basically we're doing a bypass of the diseased area. So common ones that you may encounter are patients who had a femoral popliteal or FemPop bypass, where you're connecting the femoral artery and going around to the popliteal and kind of doing a distal popliteal area. If it's higher up, you may have an aortofemoral bypass, where the aorta, a graft is placed between the aorta and the femoral artery. Then we talked about thromboembolic disease, where you have a blood clot that forms and then gets sent downstream. And there's lots of reasons why these blood clots may form in the first place. But depending on where it goes determines what you're going to see. So you can get an acute limb ischemia if it goes to one of the arteries that affects the lower extremities, the extremities. Or if it goes to the mesenteric ischemia, then they may start to get mesenteric. It can affect the superior mesenteric artery or the inferior mesenteric artery. But remember that the 6 Ps are present in somebody with this thromboembolic peripheral arterial disease. And the treatments for it is give them heparin immediately while you're figuring out what's the next step for these patients. And typically we got to go in and we have to be aggressive in going in and removing that clot to restore blood flow. And then we talked about the giant cell temporal arteritis for inflammatory conditions. We talked about the vasospasms that you get with like Raynaud's. We talked about how with Raynaud's we can do calcium channel blockers to help if avoiding cold does not treat their condition. And then we finished this by talking about AVMs, how these are benign things, but unfortunately can have some negative consequences associated with it. And depending on the location, we could either do embolization, so we're blocking that blood flow through that connection, or we can do sclerotherapy, where we're injecting things underneath the skin that causes a hardening of the vessel to prevent that connection, that direct connection from the artery to the vein. That brings us to 2:50, so 2 hours. Questions? Okay. All right, well, I will see you all Friday. If you have any questions that come up, please do not